talk. And our institution receives support for a trial which I will not particularly be talking about, but I'm happy to. And then this is sort of the standard, thanks to a large list of people, and I really regret not being able to name all the people involved in the projects I'm going to show here. I do make the general point whenever I give this sort of talk that that all patient-based research is a team sport. There's really no such thing as somebody doing high-level patient-based research as just in their lab alone. That this is a highly collaborative way of learning new things about disease, and so I really encourage people to take advantage of collaborations, both for to make progress and also as a really satisfying way to form new relationships. I'm going to be talking about amyloid angiopathy, which the field I've been working in for a long time. It's an interesting history in that it was described pathologically really before it was identified as a clinical entity. It was only the second half of the 20th century where people realized the amyloid in the vessels does something. The first version of the Boston criteria for diagnosing CA during life were proposed in 1995. And, I mean, I'm at a point where I like to look back and say, well, we've really come a long way. I mean, so it's now, I think, pretty widely recognized as a very prevalent pathology and a major cause of spontaneous or antithrombotic related intracerebral hemorrhage. And separate from that, an independent contributor to age-related cognitive decline, as shown here at in some of the figures taken from the Rush Memory and Aging and Religious Disorder studies, where small vessel disease, vascular disease in general, is very commonly present and a contributor, and to show amyloid angiopathy is having very substantial prevalence and a modest but still important contribution to the overall picture of age-related cognitive decline and affecting cognitive trajectory over time. And then, of course, this extra role has emerged. I will be talking about it during this presentation of its role in the ARIA, the major side effects associated with the anti-amyloid immunotherapies now in use for Alzheimer's disease. So this will be the organization of my talk. I'm going to spend the first part talking about the pathogenesis of CA and the updated version of the Boston criteria. They're calling the version 2.0. In the middle part of my talk, I'll touch on a really common practical question that comes up, which is CA and the decision to anticoagulate, how to balance the risks and benefits. And as I mentioned, I will close the talk discussing CA's role in anti-immunotherapy, in particular generation of ARIA, and how we think about ARIA in treating people with anti-amyloid immunotherapy. So starting with the pathogenesis, I'm showing here my teacher for many years at Mass General Hospital, now for many years at Columbia, Jean-Paul von Sattel, and laid out this pathogenic scheme. And this is all, of course, in cross-section. Pathology is always a cross-sectional field, but actually, we believe this corresponds pretty well to the temporal progression of CA as well. So what you see in the upper left-hand figure here, I think people can see my cursor, is an almost normal vessel. This is the earliest staging recognized of amyloid angiopathy. So this is a vessel in longitudinal section. The lumen here is off the bottom of the slide, and the adventitious at the top of the slide. Most of the slide is taken up with the media here in longitudinal section, and it's almost completely normal media. The only thing that's abnormal are these smudgy kind of donuts right at the media adventitia border. Those are Congo red staining and react to anti-amyloid antibodies. They represent the earliest stages of CAA. And a point that Jean-Paul made is that I used to call this the tombstone of the smooth muscle cell, because you see these kind of optically empty donuts, and at least visually, it looks like what used to be in them. What we believe is in fact the case was the smooth muscle cell that has been encased with amyloid and then died. Then what you see in the upper right here is the next more advanced stage, where essentially the entire vessel wall has been replaced with amyloid. So there's now very few living smooth muscle cells. In the media, you see under polarized light the classic green birefringence for the Congo red stain. That's the hallmark feature of all amyloids, reflecting the high beta pleated sheet content of the amyloid deposits. And so on the one hand, you look at this vessel and you say, well, it still has integrity. It's not ruptured. On the other hand, it looks like a very abnormal vessel that's going to lose normal reactivity. And as I'll show in a moment, that we believe that is in fact the case. And then at the bottom, you see the most advanced degenerative stages in the vessel, where the vessels now have this fibrinoid necrosis change, and we believe that's the most proximate correlate of the hemorrhages that are the way we often recognize CEA in clinical practice. And when it comes to diagnosing small vessel diseases, I mean, I always say this is kind of a good field for simple-minded people like myself, because there are really only two common small vessel diseases of the brain in aging, cerebral amyloid angiopathy and arteriolosclerosis. They tend to have different predilections, with amyloid angiopathy mostly affecting these leptomeningeal and cortical penetrating vessels, causing the classic lobar distribution of hemorrhages that we now recognize, and as we'll talk about in a moment, are the really the hallmark criteria for the Boston criteria for diagnosis, and that's in contradistinction to the predilection of arteriolosclerosis or lipohyalinosis to the deep penetrating vessels, causing the greater tendency of arteriosclerosis to cause hemorrhages in deep hemispheric structures like putamen, thalamus, and brainstem. And so this almost yin and yang relationship serves as the basis for our ability to diagnose the diseases during life. And what I'm going to lay out here, and I'm showing the people involved in this scheme. The pictures are of Emma Komans and Marika Vermeer, who are collaborators at in the Netherlands. The lower left, Jasmir Chadwell, who's here at Mass General Hospital. Actually, I collaborate with him through his role in the Diane study. And lower right, Susanna van Velu, who has been involved in many of the pathogenic studies that I'm going to be showing here, and has led many of them. And the scheme is now meant to be a pathogenic scheme over time. So rather than talking about the pathology again at postmortem, this we believe is the way that CA progresses over time. A lot of this work has come from hereditary forms of CA, in particular the Dutch type CAs. I'll show in a moment that because that's a 100% penetrant form of CA, it allows us to look at CA progression over time. And so we have the scheme of first vascular amyloid deposition, followed by alterations in vascular physiology, that loss of normal reactivity that I alluded to, then non-hemorrhagic brain injury, and then only finally hemorrhagic brain injury as the last stage, the culminating stage in CA pathogenesis. So let's walk through that. And so I mentioned the Dutch type hereditary form of CA. It's a single amino acid substitution within the beta amyloid coding region of the amyloid precursor protein, autosomal dominant, 100% penetrant, and looks a lot like sporadic CAA, with the exception that it's completely predictable, the 100% penetrant, and the age of first hemorrhage is substantially younger. So first ICH mean age of 54. And then with, if anything, a higher annual recurrence rate, that 20% rate is even higher than what you see in sporadic CA, which is already a very aggressive recurrent form of disease. So where do we get these first few steps, vascular amyloid deposition, alterations in physiology? Well, there are two ways that we've used in life to measure the early stages of vascular amyloid deposition. One is by amyloid PET imaging, which I'm not particularly showing here. The other that appears to be more sensitive is to look at reductions in CSF amyloid. And this actually refers to both the A beta 42, the longer amyloid form that people in the Alzheimer world are used to, is using a CSF using as a CSF biomarker of Alzheimer's disease, but also the shorter form, the A beta 40, the 40 or shorter amino acid form that is tends to have greater representation in the vascular deposits, and both of them are reduced, as you see here, and they're reduced even in those pre-symptomatic people relative to similar aged non-mutation carriers. And you can measure these changes 2 to 3 decades before the first hemorrhage. So we're using that age 54 as kind of the anchor point. So that means that people in their 20s and 30s already are showing reductions in CSF amyloid that we suggest correlate with the earliest vascular amyloid deposits. Then this next stage of alterations in vascular physiology, we measure using a functional MRI study. So this is a bold response to visual stimulation. We like visual stimulation because there's a lot of amyloid in occipital cortex. And here, about 2 decades before, so a little later than we can first measure CSF changes, but really quite early. So people in their 30s. So these are pre-symptomatic individuals. Their MRI scans, I'm not showing here, but look normal. They're normal. They have no clinical symptoms or signs of any sort, but already demonstrate this lower amplitude response as well as a delayed response, a longer time to peak response in their bold response to visual stimulation. So that idea that, and we think the most straightforward explanation is that this is from that loss of smooth muscle cells, that if you don't have smooth muscle cells, your vessels can't dilate in response to neuronal activity and the neurovascular coupling. And there may be other mechanisms as well, but that's a straightforward mechanism that would explain this early loss of vascular reactivity. Then the more advanced stages, first what we refer to as non-hemorrhagic brain injury. So measured here, for example, is white matter hyperintensity that we're all used to as clinicians seeing all the time. And then I think many people will be familiar with a marker developed by Marco Düring in Munich of PSMD. So that's if you take the white matter where you form a white matter skeleton, so skeletonized white matter in analysis, and measure the mean diffusivity of all the voxels in the white matter, and just make a histogram and look at the width of the peak. You get a widening of that peak as what appears to be quite a sensitive and robust marker of microstructural disorganization. So whether you're measuring, this is work done by Zara Shirzadi working with Jasmir Chatwal, that you see these changes now 1 to 2 decades. So people in their 30s and 40s are showing the early signs of white matter hyperintensities and this widening of the mean diffusivity histogram. And as you can see here, that progresses over time. So it appears to be a strong marker for this non-hemorrhagic stages. People still often have little or no clinical impairment, but demonstrate changes in white matter without hemorrhagic lesions. And then the most advanced stage is appearance of first hemorrhage, as shown here again at that age, mean age of 54. So that as I said, we've used that as the anchor point. And so just flipping what I said before, 180 degrees. So it's 1 to 2 decades after the first white matter lesions, you see that mean age of first hemorrhage. So you can plot all these together, and don't worry here about the crossing of the lines. That probably doesn't tell you anything. The important thing is sort of when the lines begin to take off. So if you plot, again, using what's 0 on the x-axis here of this graph is that age 54, again, fixing everything to the mean age of first hemorrhage, that you first see the reduction in CSF amyloid, then the loss of bold reactivity, and then the appearance of white matter injury. This is plotted from individual level data. So this is actual data, although it's plotted data as we showed. And so this gives this timeline of 30 years plus. And I just mentioned here, I won't talk about it at any length, but there's sort of a parallel line of evidence to give this kind of 30 to 40 year time course. And that came from a completely separate line of evidence, not from hereditary CA, but from this iatrogenic form of CA. So literature developed, this is a review article from Gargi Banerjee, who worked with David Waring, has generated a lot of the thinking in this field. The idea is that children who've gotten neurosurgery, especially neurosurgery where there's documented use of cadaveric material that may be amyloid containing, that's no longer done in practice, not because of concerns about prion disease, but it probably is also transmitting amyloid disease. So biologically, it's quite interesting that you can transmit amyloid disease, especially CAA. But just from the standpoint of this timeline, if you look at the mean duration between the neurosurgery and when these now young adults get, or middle-aged adults, but in their 50s or 40s get first hemorrhage, it's that same 3 to 4 decade time lag. So again, very different lines of evidence, different biologies, but comes out to a pretty similar number that CA progresses over this 30 to 40 year period. So to summarize this first part of my talk, I think you can make the argument that CAA represents a decades-long process of beginning with vascular amyloid deposition, alterations in physiology. The non-hemorrhagic lesions that I'm not showing here, but in our hands are the best correlate of cognitive decline related to CAA. And then finally, the hemorrhagic lesions that present like stroke. And it's sort of this irony that we all think of CAA clinically as being a hemorrhage disease, but it is in fact, that's the last thing that happens, not the first thing that happens. So by the time you bleed, you've got what appears to be advanced disease. Turning to the diagnosis and as I mentioned, hemorrhagic lesions on the one hand are the last thing that happens. On the other hand, they are still the key diagnostic feature because we're not good enough at picking up the other steps or knowing that they represent advanced CAA. This is one set of diagnostic criteria that were developed by Mark Rodriguez and Rustam Al-Shahi Salman in Edinburgh. So the Edinburgh criteria, these are based on the CT appearance of hemorrhages. This obviously only applies to people who have a lobar hemorrhage, and that this characteristic appearance of subarachnoid involvement, so some of the hemorrhage making its way or some involvement of subarachnoid space with the hemorrhage, and these finger-like projections, as you see on the right here, which don't have an amazingly good inter-rater reliability. It's a little subjective, but these things that are longer than they're wide, and the presence of subarachnoid hemorrhage. They also included ApoE in their criteria, although ApoE testing is not generally done in practice. So, but even just sticking to the CT appearance, there's some diagnostic yield that you can look at a lobar hemorrhage, and with some degree of accuracy say that it looks like a CA-related lobar hemorrhage. But really, what's been the more informative marker in general have been the ability to detect microbleeds and an MRI-based method, and that was, of course, been the basis of the Boston criteria from their inception, is the ability to look at to use MRI to detect not just the acute hemorrhage, but all hemorrhages, microhemorrhages, macrohemorrhages, and sulcal bleeding, as we'll talk about in a moment, the cortical superficial siderosis, and actually we'll talk about it right now. So this is you see not only the microbleeds associated with CA, but also either in chronic form, this cortical superficial siderosis that shows up in the sulci, especially of people with CA, not can come from other causes, can also come from a traumatic injury, for instance, but when happening spontaneously, also carries weight for CA. And in the acute phase, it appears as a convexity subarachnoid hemorrhage, the main difference being that it appears bright on flare, and that the acute blood doesn't suppress the way CSF suppresses with flare. So that led some years ago to what has been referred to as the modified Boston criteria. We're in retrospect calling it the version 1.5, and this has been the criteria for some time, that the appearance of multiple hemorrhagic lesions, and that can be large hemorrhages or microbleeds, and then you sort of get one more if you have any degree of cortical superficial siderosis in the modified Boston criteria. So the multiple part means at least two. The strictly part means that you don't meet criteria if you have any hemorrhagic lesions in the deep hemispheric regions that I showed earlier as characteristic of arteriolosclerosis, that you could, even in the absence of pathology, be diagnosed with probable CAA. And just to mention a few points relevant to this, one is I think everyone's very aware that the techniques around microbleed detection, the T2 star weighted techniques, make quite a big difference in terms of the sensitivity of the method. So we used to think that just the regular old clinical T2 star methods, the GRE methods, were pretty good, but they become much more sensitive with a variety of techniques. So the ones I mentioned here: increased echo time, thinner scanning sections, higher magnetic field strength, so 3 Tesla versus 1.5 Tesla, the image post-processing methods, so things to generate the more conspicuous microbleeds using the phase information as well as magnitude information, that's susceptibility weighted imaging, or multiple TEs that give the SWAN technique. And these matter. We've done some years ago, we did side-by-side MRIs using conventional methods and using one of the more advanced methods, and you definitely detect more, as up to 3 times as many microbleeds using a more advanced method. Whenever I I describe a scan that I'm looking at. I always say what the method was because that's clearly related to the sensitivity and also goes to comparing one scan versus another in longitudinal scans. And the other thing to mention here is just on the location of the microbleed. So what you see on the left is what we would call a probable hypertensive or a probable arteriolosclerosis pattern with lots of involvement of thalamus, as you see here. But the reason I put the arrows here is to show that arteriolosclerosis is almost certainly not as specific for its region as CA is for its region. What I mean by that is that you clearly can get lobar microbleeds in arteriolosclerosis. This could be both pathologies mixed together, but there's a decent chance this is purely arteriolosclerosis alone, as is the case in this scan I'm showing here. And then the probable CA one, I just mentioned that even things that are at the gray-white junction can look pretty deep because of the way the cortical ribbon loops around to the medial aspects of the brain. So we would still consider this at the gray-white junction and a good location for CAA. So a few years ago, Andreas Charidimo, who's now at Boston, University of Boston Medical Center, and I reviewed the studies that had been done to validate the Boston criteria. And they seem to have, especially the modified criteria, to have high specificity for CA-related intracerebral hemorrhage and pretty good sensitivity. Weren't detecting everybody who had it, but pretty good. And this is comparing the people who had imaging and then also had pathology. And then if you looked at non-hemorrhagic presentations, specificity is still pretty good. Sensitivity clearly lower in a population-based study, really quite low, meaning lots of people had advanced CA pathologically, but did not meet the Boston criteria. So the goal, and this is Andreas Charidimo, who led international collaboration to update the criteria as published now a couple of years ago. So the goal was to update the criteria with emerging markers. So what other markers could we add to try to improve the sensitivity without compromising the specificity, and then to do much more widespread validation across both multiple time periods and across multiple centers, and to we pre-specified looking separately at ICH and non-ICH presentations, and to sort of jump to the new markers that got involved. Well, one I think of as kind of a technical fix that I mentioned before in the modified criteria. You only got credit for sort of one extra hemorrhagic lesion with cortical superficial siderosis, no matter how many foci of cortical superficial siderosis you had. So one thing that we proposed and then validated was to count separately the multiple foci of cortical superficial siderosis. So what this means from a practical standpoint is you could be diagnosed now with, under the 2.0 criteria, and I'll show the validation in a moment, you could be diagnosed just with multifocal cortical superficial siderosis. So you could now reach that multiple, at least 2 hemorrhagic lesions just by at least 2 foci of cortical superficial siderosis, as shown here. The other, though, is, things that we added that we and then validated were non-hemorrhagic markers. So this is sort of dipping our toes into some markers that may occur earlier than hemorrhagic lesions. One of them is having a severe number of visible perivascular spaces in the centrum semiovalle. So these are seen on T2. I always kind of joke when I give this talk that I used to kind of ignore the T2 sequence, but T2 is the sequence of choice. I would just go right to the flare, but T2 is the sequence of choice for seeing perivascular spaces because they have CSF density in them, and the CSF gets suppressed on flare, but is seen on T2. And so when you have at least 20 visible perivascular spaces in one hemisphere in the centrum semiovalle, that's the severe level, and that has some specificity for CAA. And what you see on the right, and this was an observation by Adip Garol working in our center, that this multi-spot pattern of white matter hyperintensities, for reasons we don't completely understand, we're not sure what the link is to CAA, but that does appear to be to carry some sensitivity and specificity for CAA. So what you see here are the criteria that we derived in one cohort and then validated in an independent cohort. And what's in the boxes are the main changes. So one is that you could get to that at least 2 hemorrhagic lesions purely by having 2 foci of cortical superficial siderosis or convexity subarachnoid hemorrhage. And the other change is that you could also meet the criteria by having one hemorrhagic lesion plus one of those white matter features. That would also get you to the probable CEA diagnosis. So what you're seeing here is validation. So this is the derivation cohort. So you'd expect it to perform here. This is the cohort we use to first derive those additional features. So specificity is still good, but the sensitivity was higher than what we had seen before. And then the two validation cohorts, one is an independent cohort over a different time epoch here at Mass General, and the other, the geographical validation, is across multiple international centers. And you can see, if anything, that sensitivity performed even better especially in the temporal validation, but really both the validation cohorts and the specificity did not appear to be compromised. The area under the curve did not appear to be compromised. So this was strong evidence that these results are generalizable, and we pre-specified a comparison in just the people with autopsies, with the idea that people with biopsies or evacuated hematomas, we might have some false pathology findings. So we consider this the goldest of gold standards, and sensitivity and specificity were quite high for intracerebral hemorrhage. Still lower, but improved sensitivity for the non-ICH presentations. And if we look at the area under the curve, it was superior to the 1.5 version. So we feel we've succeeded in our goals of improving sensitivity without taking too big a hit on specificity. And I'll just mention that if you look only at the people who had SWI, the sensitivity and specificity was really good. So with more sensitive MRI techniques, it seems like, if anything, that the methods get better. So to conclude the discussion of the diagnosis of CEA, so probable CEA now encompasses these two additional groups with multiple foci cortical superficial siderosis, or one hemorrhagic lesion, one of the white matter lesions, and it's still true that specificity is better than sensitivity for the non-ICH presentations, although it is improved with the new criteria. So I'm going to turn from this to the second part of my talk, which is CA and the decision to anticoagulate. And so this is a classic situation that I think everybody, all of us who see stroke patients are in this conundrum from not infrequently, where somebody really looks like they've got CA and they also have atrial fibrillation with high enough CHA2DS2 VASc to be good candidates for anticoagulation. And the question is, what do you do? So, and this is C. Miller Fisher here, who I was lucky enough in my training to still sort of learn at the feet of just incredibly powerful thinker. And I know this quote's accurate because I heard it, so I wrote it down as best I could. If you're treating even one patient in your practice with anticoagulation, you should wake up once a week or so in a cold sweat. And it's ironic coming from Fisher, because he really put anticoagulation in a very prominent spotlight for treating AFib. So he was a big believer in it. He helped prove that it was effective, but also respected what a double-edged sword anticoagulation. This is still true in the DOAC era. This as you see here, this 50% mortality and warfarin-related hemorrhages. This was true 20 years ago, and it's still basically true that the mortality does not, the incidence of intracellular hemorrhages, I'll talk briefly about, is lower with DOAC use, but the outcome is still dismal regardless of using a warfarin or a DOAC. So this still remains a highly dangerous treatment, and so deciding who should and who shouldn't get anticoagulated still remains a really high stakes decision. And the reason this is particularly a big deal in CA is the high rate of recurrence. I mentioned it before, and what you see on the lower left was a collaboration from European groups looking at the risk of recurrent hemorrhage across different types of primary intracerebral hemorrhages, and CA, out recurs all of them. This is very, very high recurrence rate. Again, also shown in the pooled analysis in the upper right, where something like 8 times or more higher likelihood of recurrent hemorrhage among the people with CA related rather than non-CA related intracerebral hemorrhage. And I just I think I lost the table. Let me keep going. So question is, can you anticoagulate after a lobar hemorrhage? And it's sort of an interesting situation where decision analysis has argued originally that it's a bad idea, but then there were retrospective analyses that say maybe you can, that that it didn't seem like among people who were in a non-randomized way given anticoagulation, resumed anticoagulation after a hemorrhage, did not seem to have worse outcomes than people who were anticoagulated. If anything, you seem to be preventing new strokes without causing new hemorrhages. So the question, this was enough equipoise to go to multiple clinical trials that I think people are aware of. So there's now been multiple trials, including an ongoing one from Aspire via StrokeNet. And you see that all the ones that specified anticoagulant specified use of a DOAC. That's because of the lower risk of intracerebral hemorrhage, intracranial hemorrhage associated with DOAC use. We think the reason that that's lower risk of intracranial hemorrhage with DOACs relative to warfarin, we think that relates to the high levels of tissue factor in the brain, so that because of the greater non-specific specificity of warfarin, of decreasing the activity of factor 7, factor 9, would tend to lead to greater numbers of intracerebral hemorrhages compared to the more specific inhibitors of factor 10 or factor 2 as the DOACs do. And so I'd love to tell you that we have a little bit of data from these studies, and I'd love to say that, there's no higher risk of hemorrhage in people who get randomized to anticoagulation, but that seems pretty clearly not to be the case. So whether you look at people randomized to anticoagulation, or even more so if you look at people who crossed over to anticoagulation for one reason or another, that there seems pretty clearly from the Apache AF and the SOSTART results that have been reported to be higher numbers of intracerebral hemorrhage in people who in these randomized studies were assigned to anticoagulation or received anticoagulation. And then this probably came to its peak in the Enrich AF study led by Ashkan Sholmanish at McMaster. And in this study, the DSMB said that they had to stop enrolling lobar hemorrhage patients to randomize them to edoxaban or no anticoagulation because of the unacceptably high risks of recurrent hemorrhagic stroke among patients with lobar intracerebral hemorrhage or convexity subarachnoid hemorrhage. So, what does this mean? Well, it doesn't. In the case of Enrich AF, the DSMB said, the risk is too high to even continue randomizing. The other studies have not come to that conclusion yet. Aspire is still ongoing. But I think if nothing else, we can say that there is no free lunch. There is no anticoagulation without risk of intracerebral hemorrhage. So it doesn't mean that it's the wrong choice, but it does mean that that it's going to come with I think the evidence would say that it comes with increased intracerebral hemorrhage. This idea that there is no higher risk of intracerebral hemorrhage was too good to be true and appears not to be true. So we do have some more reassuring data from antiplatelet use. So this is work from, again, Rustam Al-Shahi-Salman, who led the RESTART study run out of Edinburgh, and that over now 2-year and then 3-year follow-up, there was no higher risk of recurrent hemorrhage in people who were restarted on their antiplatelet. So, and this is antiplatelet almost always means aspirin here. So restarting aspirin in somebody with an intracerebral hemorrhage does not appear to cause much. If anything, in the first study, there's actually a lower point estimate for recurrent hemorrhage among the people who were randomized to restart their aspirin. That benefit seems to have gone away, but there doesn't seem to be a detriment. There doesn't seem to be higher risk. So this study definitely has affected my practice, and I felt more confident in restarting antiplatelets. The other option from my standpoint is a very rational option to consider is left atrial appendage closure. Its use has definitely increased at our hospital, and I believe at others as well. This is a meta-analysis from a few years ago showing that people who in randomized studies who received left atrial appendage closure rather than anticoagulation definitely had lower risk of hemorrhagic stroke. Well, that's not too surprising. I mean, because they're, you're able to get them off of anticoagulants. It's not clear. It wasn't clear as of this study whether left atrial appendage closure was as effective for preventing ischemic stroke in the AFib patients. As you can see, the point estimate just barely overlaps 1, and so there was a trend towards more ischemic strokes. The people in this field believe that the newer technologies have gotten better, that the surgeons gotten better. So maybe that number will come down in future studies. But I think if nothing else, in people at very high risk for recurrent hemorrhage, this is a rational option, and I've voted with my feet. They're patients I've referred to get left atrial appendage closure. So this the CA and the decision to anticoagulate, I have the scale there because this is a really tough call. So each decision, it's a personalized weighing of risks versus benefits. I don't think there's a one size fits all answer. Depending on this comparison of the embolic versus the hemorrhagic risk, I think there's situations where DOAC is a rational thing. An antiplatelet, I think, is a rational thing for the reasons we talked about. Left atrial appendage closure, I think, can be a rational option. I think warfarin probably loses in any situation where a DOAC is an option because of the lower intracranial hemorrhage risk. And there aren't too many people where I do nothing anymore. I feel like I'm reassured enough from the RESTART data to say that antiplatelet use appears to be safe enough to make it a better option than no treatment. And I just mentioned limited duration treatment is less risky than indefinite. So, because people often worry, if I don't want to do left atrial appendage closure because I'm going to have to give some intensive course of either dual antiplatelet or anticoagulant for some number of weeks. But it's not just what you give, it's how long you give it. And shorter duration is safer than longer duration. So I feel better about that than indefinite anticoagulation. And I think clearly a win is to minimize other sources of risk. For example, blood pressure control is purely a win from my standpoint because it reduces the risk of both hemorrhagic and ischemic stroke. So for the remainder of my talk, I'm going to move to this area of CA and anti-amyloid immunotherapy with particular regard to ARIA. And obviously, this has come into focus because of, this is something that many of us would have, sort of given our eye teeth to have we have what appears to be disease-modifying treatment or treatments for Alzheimer's disease. And that's, it's a big deal. It's not the cure that we would have wished for. And you can decide how clinically significant that slowing of progression is with here showing lecanemab versus placebo. And particularly if this separation between the curves continues over longer periods than the 18 months in the trials, then you can begin to feel like we're going to have a real impact on the course of Alzheimer progression. And the bad news is almost completely around ARIA. ARIA really seems to be the ARIA H, the hemorrhagic lesions, and ARIA E, the effusions or edema, are the major adverse effect associated with the amyloid therapies, and that are considered the greatest limitation to their use. And the reason that this is particularly of relevance to a CA talk is the close similarities between ARIA and this CAA-related inflammation. So this was a syndrome that we and others have described over the years, where there appears to be an autoimmune response that is spontaneously generated. So it's not from somebody giving you an antibody, but that you yourself generate an immune response to the amyloid in the blood vessels. So I put side by side here people with antibody-related ARIA on the top and the spontaneous syndrome of CA-related inflammation on the bottom. And they look, well, I picked the images here to look similar, but they really look almost identical. And I think there's good reason for that. I think they're closely related syndromes. Whereas we have only limited pathology on ARIA, we do have substantial pathology on people with this spontaneous CA-related inflammation, and it looks very much like an autoimmune response. You can see here infiltrations of inflammatory cells, specifically around the amyloid-containing vessels. In some cases, you see these multinucleated giant cells that appear to be engulfing amyloid. So the idea here, as we discussed in a review article a few years ago, is that it's possible that some of this response may be driven by amyloid being mobilized from plaques into the perivascular space, into the vessels, and that some of it, maybe much of it, is generated by the antibodies actually binding to the amyloid in the vessels and causing some kind of blood-brain barrier breakdown. So, if you look at the shared features, so the MRIs look similar. The role of anti-amyloid antibodies is work from, Fabrizio Piazza a decade ago, showing elevated generation of autoantibodies to amyloid in the CSF of people with the CA-related inflammation. And at the bottom, what you see here, this is work from the that I presented on behalf of Eli Lilly at the CTAD meeting last year. And this is looking at risk factors for ARIA in donanemab, and this is auto-advancing. Let me see if I can slow it down for just a minute. Presence of multiple E4 alleles, presence of baseline microbleeds, and presence of baseline cortical superficial siderosis were all independent predictors of which donanemab recipients would develop ARIA-E. So this is, I think, a strong argument that having pre-existing CAA is a really good substrate for developing ARIA subsequently. So that's an interesting finding. Just mention this one other finding that was unexpected, but I think is notable, which is people with lower mean arterial blood pressures at baseline. So this is before you start the treatment, were at lower risk of developing ARIA. So then the higher your blood pressure at baseline, this is just a single snapshot, what your blood pressure was when you started receiving the medicine, also was an independent predictor of having ARIA. And I think this is an intriguing idea that there may be a modifiable risk factor for ARIA. This only showed up in the one study. I think it needs to be replicated, but it's quite intriguing. We developed some years ago diagnostic criteria for CA-related inflammation, and it's basically trying to put in words what the images look like, especially the, as mentioned in blue here, the focal or asymmetric white matter hyperintensities extending to the immediately subcortical white matter. And this seems to have a high sensitivity and specificity for being able to diagnose CA-related inflammation in practice. And the study led by Robbie Regenhart and Jesse Thon here was a retrospective analysis of all our CA-related inflammation patients, and in particular, the response to therapy. So what you see on the left is that this, what's really an empiric treatment protocol that we use for the spontaneous CA-related inflammation of corticosteroids as the first line of agent, reimaging, and then consideration of cyclophosphamide as the second line agent, leads to short-term both clinical and radiographic improvement. And when I say leads to, this is retrospective. This is not a randomized study, but the people who got immunotherapy were more likely to improve than the people who got immune suppression were more likely to improve than the people who didn't. And then what you see on the lower right is a surprising finding that the people who received immune suppression also had lower risk of recurrences, so they had fewer recurrent flares. So this has affected my practice to some extent. This makes the argument that not only can you make the immediate flare go away, but that you may lower the risk for future flares of this CA-related inflammation. So, well, in general, you don't necessarily feel like ARIA is automatically dangerous, but then there are case reports like this one from Matthew Schrag and colleagues at Vanderbilt. This was fatal ARIA in the lecanemab study. So this is now in the open label phase where this person got open label doses, was developing headache, maybe in retrospect, that was a clue as to what was going on, but then vasogenic edema and, pathology that really looks like CA-related inflammation. So I think this, further strengthens the link between CAA and ARIA. And then, so that's bad ARIA-E. Can you get bad ARIA-H? Can you get macrobleeds? Well, on the spontaneous CA-related inflammation, we don't see a whole lot of hemorrhages. We have, one image here in a paper we published a while ago of a lobar hemorrhage. You don't think of big hemorrhages as being a big part of CA-related inflammation, but there's at least this one case that maybe many people saw was published by Sherry Chu and colleagues from Northwestern, where an individual, again, in the open label phase of lecanemab, had what appeared to be a stroke-like event. You kind of wonder in retrospect, was it actually a stroke? Hard to know. Got IV TPA and then had this, the imaging shown here and the autopsy shown here. And of course, you never want to see something like this. It's, just a sort of awful looking multifocal hemorrhages that the patient died from. Again, at autopsy, had clear CA-related vasculitis, making the argument that this was a person who was developing the severe ARIA, and then IV TPA was putting, in retrospect, was throwing, gas on the fire to lead to this deadly situation. And it raises questions, in the lecanemab study. If you look across the different studies, the randomized and closed label, there's small numbers, but it seems to be an elevated likelihood of hemorrhage in the people who were receiving both anticoagulants and lecanemab. So, here it's just my listing of the clinical dilemmas that are facing us in my as vascular neurologists when we weigh in on people receiving amyloid immunotherapy, receiving lecanemab. So, should you give it to people with known small vessel disease, with known CA? Well, what we can say is the trials allowed up to 4 microbleeds, up to 1 focus of CSS, no prior ICH. It seems following those guidelines seems like a reasonable thing to do. Should we let people in the lecanemab who are on anticoagulants or on antiplatelets? So from the antiplatelet standpoint, at this point, there's no evidence for increased intracerebral hemorrhage risk. So we here at Mass General, and in general, my feeling is there's no reason to keep people on antiplatelets off of, I keep saying lecanemab since that is the major agent in use now. Aducanumab no longer being marketed, and donanemab not yet approved. The more recent studies allowed anticoagulates, but the suggestion of increased ICH risk. So there's a real question of whether people on anticoagulants should be allowed in. I think reasonable to think that they shouldn't be, that's too risky for the reasons that we've talked about, the very deadly nature of anticoagulant-related hemorrhages. How to treat ARIA? There's no established treatment other than holding doses, but based on the evidence that steroids improve CA-related inflammation, it's at least a rational thing to try. No evidence at this point that steroids work for bad ARIA, but I think that is generally being used. And then this other question, acute thrombolysis, such as that TPA given the one Northwestern patient. So there's no guidance from the trials. They didn't have a specific policy, but clearly may be risky. I would say there's no evidence that, no reason to think that mechanical thrombectomy is problematic. So I think that's in an ideal world where a patient who's receiving lecanemab has a large vessel occlusion, that mechanical thrombectomy should just go ahead with PACE, because there probably won't be a thrombolytic option. I think this is a good area for advanced directive planning. This was an idea that came up in a JAMA editorial, and I think it's reasonable when somebody starts on lecanemab to say, okay, what do you want to do if you're in a situation, and it's not just stroke, it would also be a pulmonary embolus or other things where you need acute thrombolysis. Should we do it or should we not do it? And I do mention the last thing, beware of ARIA presenting as a stroke mimic, because I think the focal deficits that ARIA generates could be mistaken as a stroke and lead to thrombolytic treatments that aren't necessarily needed. So I'm going to close here and open for questions, at least some time for questions. So I think it's reasonable to think of ARIA as being essentially an iatrogenic form of this CA-related inflammation. Goals are to improve ARIA prediction, prevention, and treatment. And I'll just mention here, there's no role at this point for anti-amyloid immunotherapy as a treatment for CA. There's no evidence of benefit and substantial concerns about safety. I'll just mention that if you can't get enough of this stuff, we have what's always a really good event, which is the International CA Conference coming up in Munich, a great, really fun city to visit, and that will be October 15th to 17th. They tell me in Germany something's going on in October. It seems like a popular time to travel to Germany, but we've been able to book our conference there anyway. So if anyone wants to make the trip, I look forward to seeing you. Let me stop there and open up for questions. Thanks very much for your attention.
Thank you, Dr. Greenberg, for the comprehensive discussion. If anybody has questions, they can unmute themselves, or you can drop it in the chat box. There is one question on the chat box. They're asking, does high altitude or plane flights pressure differences increase the chance of bleeding from CAA?
Yeah, thanks for asking. And patients ask it a lot, and I try to anticipate the question. My answer is that there's not either, theoretical or empiric evidence that it's risky. I don't, you always wonder what it's a whole literature, as people know, on plane flight related conditions and, blood clots in the legs, lower PO2, but no, there's not a theoretical reason to think that there's higher risk of vessel rupture. And, for what it's worth, I haven't, I occasionally I see a patient who's had a hemorrhage on a plane, but it seems to be pretty random. So I don't think there's a reason for concern, and I tell people to go ahead and travel.
I also have a question. Thank you so much for the great talk. Patients who are Alzheimer patients who are supposed to be started on the same medicine, do we need to screen for CAA or based on ARIA degree, or the stage, or not?
So everybody who's getting lecanemab, I think it's universal practice to get an MRI. I think so. I think that part is so in that sense, everybody is getting screened. And right now, the criteria based on the trial. So the FDA label left some leeway, and the FDA label for lecanemab says something like, be careful about treating anybody who's outside the clinical trial criteria, but you can still, treat people as you want to treat them. But I think the practice has been, in general, to exclude people who are outside the criteria. So that means more than 4 microbleeds, more than for lecanemab, it means any foci of cortical superficial siderosis. As I showed, donanemab allowed 1 focus of cortical superficial siderosis. So I think from that standpoint, the screening happens. As I mentioned, there are some issues around counting the 4 microbleeds because you'll get higher counts from using a more sensitive method. I don't know exactly what the mix was of MRI methods used in the trials, but I think many sites use the less sensitive GRE method. So you might say, if I'll let in 4 with a less sensitive method, I'll let in a larger number, 6 or 8 or 9 or something with a more sensitive method. But I think the practice, and I think it's reasonable for now, is to exclude people with evidence of more than that. And that's basically screening for CAA.
Thank you.
I see 2 questions in the chat. The first one is from Ernest Preves. He's asking, what is the clinical relevance of possible CAA diagnosis with the new Boston criteria, especially with high prevalence of white matter changes in the population?
Yeah, so we've definitely put more focus on the probable CA and possible CA. We wanted a category, the possible CA, that would have ideally very high sensitivity, but clearly not great specificity, and that's what possible is meant to do. I don't use it particularly in practice because it just, the specificity isn't high enough, and for just the reason that you're saying in your question, that that multi-spot pattern does carry some specificity, and so it's not just having white matter disease, it has to be white matter disease in that pattern of at least 10 separate, islands of white matter, hyperintensity, or the perivascular spaces, or a single hemorrhagic lesion. I think it's fair to be skeptical about whether those patients really have CA or not. I think the level of certainty is not extremely high. The probable definition, on the other hand, does seem to have pretty high specificity, so I think you can feel more confident in that. as a marker of CA, even in asymptomatic people, seems to be. Well, I should say a caveat there. We've all the validation that we've done have been people presenting with some kind of symptom. That symptom can be cognitive impairment. It doesn't have to be a very specific symptom, but we've not validated these for use in asymptomatic people. So that's one area where the specificity may be lower, the prior probability may be lower.
The next question is, can inflammatory CAA be diagnosed non-invasively? And a question from Dr. Rotella, should family members be worked up for or imaged for CAA screening?
Right. So the first question, yeah, and I showed a bunch of slides. One of them was that the diagnostic criteria, and those are meant to be non-invasive. So that those were the ones saying that basically if you meet criteria for probable CAA and you have that white matter hyperintensity that's often asymmetric, extending all the way to the subcortical white matter, that meets criteria for probable CARI. So that is meant to be a non-invasive method. I have to say, when I first started focusing on CARI, we used to biopsy kind of everybody. We don't want to start people on anti-inflammatory treatment without having stronger evidence than just a suspicion that they had CARI. And now, based on that study, there's a large group of people who we will just make the diagnosis on non-invasively based on that MRI definition. If you want to email me, I can send you the paper, or you can look it up. The first author is Auriel, Auriel. And then the question about family members. So there's fairly good evidence, not from groups that have done larger studies of lobar hemorrhage, saying that there is an increased risk in first-degree family members, but it's not extremely high. And what I tell people, the question comes up all the time, that the hereditary forms are very instructive, but quite rare. I mean, it's very unusual, and usually it's clear cut that somebody has a hereditary form of CA, that there are multiple first-degree relatives who have early onset hemorrhage, early onset dementia. And outside of that very small group, I say it's worth having family members know that somebody in the family has CA, that your risk is probably a little bit higher than the next guy, but it's still much more likely that you won't clinically get CA than that you will. And that most of the patients that we see are the only ones in their family who have it. So there is likely a statistically increased risk in first-degree family members, but small enough that your risk of not getting it is still much higher than your risk of getting it. Right? Any other questions, guys?
All right. I don't see any more questions. Thank you for giving the time to give us this comprehensive lecture. It was really great. Thank you.
My pleasure. Yeah, thanks everybody for your attention.